I'm going to talk to you about something completely different, which is testosterone in men with advanced disease. So you've been hearing about androgen deprivation, superandrogen deprivation, and I want to talk to you about something a little bit different. These are my disclosures. So I have a research grant from Endo, consultant for A2 and for Antares, and lecture honoraria from Aceres. But I'm not going to be talking about any specific testosterone products, but the concept of testosterone. So this is what I learned, and probably all of you learned too, especially if you're over 40, which was that in terms of prostate cancer, testosterone was really the devil. I learned that high testosterone caused prostate cancer, that low testosterone was protective. I was talking to somebody earlier about men who were castrated early in life, eunuchs, were supposed to never get prostate cancer. There was one case that you presented yesterday about the guy with the endogenous testosterone level of 40, which technically is castrate with bad cancer. But this is what we learned, and that if a doctor were foolish enough to offer testosterone to a man with prostate cancer, that cancer would grow like wildfire, and we learned the terms like feeding a hungry tumor or pouring gasoline on a fire. And you know, the way I got into this, I'm having trouble with the advancing. Here we go. That's forward. All right, that'll work. Okay. So I got into this through the testosterone and prostate cancer through the back door, if you'll pardon the pun. I'm really a sexuality guy. I deal with sexual medicine and hormones and infertility as well. But I started now 40 years ago in a laboratory at Harvard, at the laboratory of David Cruz, with these cute guys. This is Anolis carolinensis, the American chameleon. And you put a male in the cage with the female, and here's the male, here's the female, and he sees the female, and if he's hormonally intact, this bright colored flap of skin comes out called a dewlap, and his head bobs up and down very quickly, and you've probably seen these guys in Florida and the Bahamas and the Carolinas. And the female, if she's got her ovaries intact, she does a very elegant push-up, and then the male comes closer, the dewlap comes out, and the head goes rapidly, and we used to joke, it was like he was going, yeah, 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 yeah. And the female does it again, they repeat it a few times, and they mate. And I didn't know I was going into medicine. I thought I was going to be a biology grad student and biologist, but first procedure I ever did in life was bilateral orchiectomy, and I did it in lizards, not humans. And if you castrate these males and you put them in a cage with the females, they don't do anything. The female will sometimes do her little push-up like, hey buddy, I'm over here, and the male does not care. He has no testosterone, there's no sexual behavior. And then my project was we'd mapped out where in these tiny lizard brains testosterone was taken up. And we knew from some comparative zoology what were likely to be the sexual centers. And my project was to put minute amounts of testosterone in the brains of these castrated lizards, males. And sure enough, if I was successful, we put these males back in the cage with the female. No circulating testosterone. And the dewlap would come out, yeah, 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 and they would mate. It was an amazing thing. And so what I learned from that before I even went to medical school was testosterone is a brain hormone, and it certainly was necessary and sufficient for coordination of the sexual response, at least in male lizards. Whether or not that was true for humans is another story, but when I came out of my training in 1988 from urology, there was very little testosterone being used in this country. Its use was restricted to men with genetic issues like Klinefelter's, pituitary tumors, or men who'd had their pituitaries resected, men who'd lost their testicles to trauma or cancer. And they got testosterone injections. And that was it. But there were very few men. And I was dealing with men with sexual dysfunction. In 1988, we didn't have that much to offer. We didn't have the pills like Viagra, Cialis. And I had this lizard experience, and so I was just curious. in 6 years of training, I'd never once given testosterone to a man. All we did with testosterone in urology was we lowered it in men with prostate cancer. But I started treating some of these men, and they did very well. And they did well in ways that I never expected. And some of these guys would say, Doc, not only are my erections better and my sex drive is better, but my wife says I'm nicer to be around. I wake up in the morning with optimism. I have patience for my small children. Really remarkable experience. But the fear was that, especially as a urologist, trained around the dangers of testosterone, that I was going to be giving these guys prostate cancer. Or that if they had prostate cancer already, and we knew about 50% of men 50 and older had microfoci of prostate cancer. So this was scary for me. So I started giving it to some of these men, and that was unusual, to say the least, because I was giving it to men who didn't have pituitary tumors. They were otherwise healthy and normal. They just had low levels of testosterone. They had 2 testicles. And so, but I was worried about this prostate cancer issue, and so I started biopsying prostates in men who had low testosterone, who were candidates for treatment and wanted it, even if their PSA was normal and their digital rectal exam was normal. Now remember that what we were taught was that low testosterone was supposed to be protective. These guys should have had an exceedingly low rate of cancer, maybe non-existent. And what we found is that that wasn't true. So in 1996 in JAMA, we published on the results in 77 men, 11 of whom had cancer. And this is just a figure from that publication. And this was our rate of cancer. So this is percent positive biopsies, 14%. And this is just studies where either the PSA or the digital rectal exam, Neil, this is your paper. Where one was abnormal or the other. These were men considered at high risk for cancer. Now, these were sextant biopsies back then. And these papers were papers where the PSA was normal, but testosterone unknown. And they did biopsies for different reasons. And I would suggest to you that our rate here of men with low testosterone, normal PSA, was much closer in its results to these studies with men known to be at increased risk than to these studies. So I no longer believed at that point that low testosterone was protective, but I still believed that high testosterone was a problem. It seemed obvious. Men get prostate cancer, bad prostate cancer, we lower their testosterone. Right? That's what we've been talking about all the last couple of days. It must be so. And in 2002, the Women's Health Initiative study about the risks of hormone therapy in women was published. And testosterone was a new topic, hormone therapy in men. The first gel was approved in 2001. And so the New England Journal was interested in a review article on the risks of testosterone. And together with my fellow Hernani Roden, who's now a prominent urologist in Brazil, we reviewed all the literature on testosterone therapy and prostate cancer, as well as population studies where they looked at endogenous testosterone levels. And what we found is that the number of articles in the PSA era, roughly dating back to 1985, that showed something worrisome about the relationship of high testosterone or testosterone therapy and prostate cancer was exactly 0. We looked and we could not find. And it wasn't that there was a lack of studies. It was kind of interesting to go back to this time, and if you look at these studies, especially the population ones, the conclusions were, we don't know why we didn't see a relationship between higher testosterone and prostate cancer. We suggest the next study looks at X, Y, and Z. And then you see the next paper that looks at X, Y, and Z, and they say, we can't understand why we didn't find this obvious relationship. We suggest they look at items 1, 2, 3. And it goes on and on. And so this was shocking, because around the world, this was a foundational concept that high levels of testosterone caused or contributed to progression of prostate cancer. And yet, the data did not exist. And so I went back to the original work by Huggins. Actually, I was on a panel giving a talk like this with Paul Lang, and Paul Lang afterwards said, Abe, you got to be a little careful. It's really interesting what you're talking about, but we all know that metastatic disease really is a whole different game. And Huggins himself wrote that testosterone is bad for men with metastatic disease. So Charles Huggins, Nobel Prize winner, together with his co-author Hodges, in 1941, I went to the back then, you couldn't get all these articles online. You actually had to go to a kind of building. Maybe you've heard of this kind of building. It's got a lot of books, and it's called a library. And I went to the basement of the Harvard Medical Library, and I found the original article by Huggins. And sure enough, they wrote that cancer of the prostate is activated by testosterone injections. They had taken guys with bony mets, and they castrated them, or they gave them estrogen, and the marker they were using, acid phosphatase, went down. And they wrote that in every case where they gave testosterone, the acid phosphatase went up. Hence, they concluded cancer of the prostate is activated by testosterone injections. And this really became the basis for, we still do this, right? I mean, this is what androgen deprivation is. And I got really nervous when I read this because Huggins was Huggins, and I was already treating a lot of my patients with testosterone. And I remember my palms getting sweaty, and I'm thinking, oh my God, some of my patients are going to get prostate cancer. This is really bad news. And I forced myself to read it more carefully. And I said, how many guys did he actually give testosterone to? And the answer was he only gave testosterone to 3 men, only for a total of 14 days. These were daily injections of testosterone propionate, short half-life. He only gave results for 2 of these men. One of these men had already been castrated, so he was already androgen deprived, and we know that's really a special category, right? Those individuals, their bodies and their prostates are hungry, if you will, for testosterone. And the remaining single patient, his acid phosphatase curve is uninterpretable. It's up and down and up and down. But the general concept that cancer of the prostate is activated by testosterone injections, or we might generalize higher testosterone, was based on only this one patient with very unconvincing results. Wow. And so this was the androgen hypothesis that really was prevalent and ruled the day for decades, which essentially can be boiled down to more testosterone, more prostate cancer growth, or more aggressiveness, or some bad feature. And if you were to plot serum T versus anything about prostate cancer, the curve went up and up and up to infinity. Maybe it looked like this, maybe it looked like this, but it was bad. And in fact, I reviewed the literature, and first published in 2006, and then with Abdul Traish in 2009, we came up with this saturation model. And certainly at very low ends of the testosterone range, we see a very important effect on PSA, prostate cancer growth, prostate cancer, anything you want to measure. But for most of the region of the range of testosterone concentrations, it doesn't seem to matter much in terms of the cancer itself. And that changes things a little bit. And so I'd like to say that testosterone isn't like food for a hungry tumor. It's more like water for a thirsty tumor. The difference being that if you drink too much water or Coke here, you're just going to go eliminate it. But if you eat and you eat and you eat, your weight will go up. And I like to use this as an analogy. So here's that saturation curve. If you think of the plant as prostate cancer, this house plant, right? And it needs water, and think of water as testosterone. If you deprive the plant of water, it'll lose mass, it'll lose volume, and if it's still alive here and you give it water, it'll grow. It'll gain mass, it'll gain volume. But once it's got enough water, once you could put a garden hose running water in there 24 hours a day, that house plant will never grow to be the size of a sequoia tree, because it's saturated with its ability to use its nutrient, if we can call water in this example, nutrients. And there are important implications of this. Now, I'm not here to tell you that ADT doesn't work. Of course it works. You've seen the data over and over and over again. You all do it because there's something important that happens in this part of the curve, right? When you deprive it, something really happens, and we kill whatever it is, 99.99% of the cells, etc. But if there's a saturation, then that has meaning for us. And one of the things it may mean is that some of these men may be able to go on testosterone without much change in their prostate cancer. But there are a couple of things here that also are important. So one is that PSA concentrations are androgen dependent. So if you give finasteride to a normal guy, his PSA declines by approximately 50%, right? Why? Because his testosterone's the same, but his DHT is reduced to castrate levels. If he goes off of finasteride, his PSA will double. Normal, healthy prostates, right? Or at least not cancerous ones. So is the prostate sensitive to androgens? Absolutely. Is the PSA sensitive to androgens? Absolutely. Because the PSA product requires androgens to be produced. So we have a funny thing where we're using PSA as a marker for prostate cancer. It's the best thing out there. It's a great cancer marker. It's useful in so many ways. But if the PSA goes down to 0 after you've given androgen deprivation, is it because you've killed all the cancer cells, or is it that the cancer cells that are there are unable to produce adequate amounts of PSA? And it may be a combination of both. So I'm actually worried more in general, in the general population, about low testosterone than high testosterone. These are mean serum testosterone levels in men based on the grade of their cancers. And you'll see that this is less than 5 and less. We don't see these anymore. 6, 7s, and 8 and higher. And high-grade cancers are associated with low testosterone, not high testosterone. This is a study from Bill DeWolf in my institution. I'm an author on this, but I think it was just a kindness because I can't really claim much work on this. But very interesting is they looked at their group of men on active surveillance, and they looked at who progressed and what the risk factors were, and they found 2. One was a prior family history of prostate cancer with a hazard ratio of 2.3, but the other was a free testosterone that was quite low at 0.45, where there was also a hazard ratio of more than 2. Low testosterone is a risk, not high. And so along the way, a number of groups have started to offer testosterone, which we never did before, to men with prostate cancer. This is the Baylor group, Larry Lipschultz, Mo Kira, and others, 103 men who received TTH as testosterone therapy after radical prostatectomy. 26 of these men were high risk. They compared recurrence rates to a comparison group of 49 men with normal T, 15 of whom were high risk, relatively short follow-up at 27 months. But the recurrence rates were only 4% in the men who got testosterone and 16% in the men who did not. I'm not going to tell you that that's better. The numbers are too small. It's not a well-controlled trial. But it certainly is not alarming. 4% recurrence rate after radical prostatectomy with a high-risk group, that's pretty good. After brachytherapy, small study, but these guys all went on it for sexual benefit, medium follow-up at 31 months. There were no cases of progression, and sexual function improved in these men, which is why they were on it and why they stayed on it. I showed some of this yesterday. This is our own group of men on active surveillance, 28 of them, Gleason 6 and 22, Gleason 7 in a few of them, half a dozen. And we compared them to 96 men who didn't get testosterone. Median time on testosterone, I don't think it's on that slide, was about 3 years. And basically progression rates were almost identical, whether the men got testosterone or not. Testosterone therapy, small numbers, but remember where we're starting from. We're starting from this is the devil, and it clearly is not. And why do the men go on it? Because they have better quality of life. So have we looked at the problem right side up, or have we looked at it sideways, and this little kitty is actually, this is the way he's there. He's on his side. And I just want to sort of bring this together with a little, as Einstein said, Gedanken experiment, a little thought experiment. I want you to imagine two brothers. They're both 60 years old. Let's make them identical twins so that they're the exact same age, the same genetics. They both undergo radical prostatectomy for Gleason. Gleason 6, few people get this now, but whatever Gleason score you want, we'll call it Gleason 6 here. And brother one comes in at a year. His PSA is perfect, undetectable. He's happy. The surgeon did a great job with his nerves. He's sexually active. His testosterone is 600. What does the doctor say to him? We say, "You're doing fantastic. You've got a perfect result. I'll see you next year," right? Brother 2 comes in. He also has a perfect PSA, but he's tired. His sex drive is down. He's got low testosterone. He says to you, "Doctor, I've been hearing about this testosterone. Can you give me some of that? I think it really might help me. My marriage is suffering a little bit. I don't feel so good." And what do we say? Well, traditionally we said, absolutely not, right? We say, "I can't give it to you. It's dangerous." And he says, "What will happen?" And what did we say? We said, "It's going to make your cancer come back." And he wasn't indoctrinated like us, so he says, "But doctor, why is it okay for my brother to have a testosterone of 600 and not me? And doctor, if you think a testosterone of 600 is dangerous, let me tell you something. I love my brother. I'm going to bring him right back in here. I want you to lower his testosterone until he feels as crappy as I do." Why don't we do that? We don't do it because it makes no sense. We were indoctrinated with an idea that was overly simplistic, which was that any increase in testosterone is dangerous for people. And it's not a simple relationship like that. As a matter of fact, the data start getting really interesting. This is a observational study of 38,000 men from the Toronto group, median follow-up of 5 years, looking at men who got testosterone and men who didn't in the records. And the new diagnosis rate of prostate cancer was lower in men who got testosterone at 2.8% compared to men who got no testosterone. And really interesting is that the longer duration of testosterone therapy, the lower the risk of being diagnosed with prostate cancer. And so last year at the AUA, we haven't published this yet, but we presented our data over the previous 5 years with men. I treat a lot of men with testosterone, different kinds of treatments for their prostate cancer. And we had 180 men. This doesn't quite add up to 180 because we had some stragglers, a few with cryo, a few with HIFU, but 86 men with radical prostatectomy. This was our rate of recurrence, biochemical recurrence. This is the literature data, 11.6% for radical prostatectomy with almost 5 years, I think more than 4 years follow-up. Radiation brachytherapy, we had 4.1%. It's not bad compared to the literature. Active surveillance, I just showed those data, was 10%. Again, not bad. So we treat a lot of people, and some of this then went on to inspire isn't the right word, but gave me some breathing room to start treating men with more advanced disease. Just as a quick little summary here, basically if you pull all the data together, and I'm not going to tell you that we have the large kinds of studies that we need to determine definitively safety, but there's not a small amount of data either. But everything we were taught, almost everything, turns out to be not so. Does high endogenous testosterone increase the risk of prostate cancer? The data suggests no. Does testosterone therapy, at least to the level that we have the data, show an increased risk of prostate cancer? No. Is high-grade prostate cancer associated with high T? No, it looks like it's associated with low T. Does testosterone therapy increase the risk of recurrence, biochemical recurrence? There probably are about 8 to 10 studies now, and none of them show increased risk. Does testosterone therapy increase the risk of biochemical recurrence after radiation? Fewer studies, but the available data says no. And what about men on AS? Very limited data, but so far, no. Wow. So I now will treat some men, highly selected, they usually seek me out, who have advanced or even metastatic prostate cancer. Why would I do such a thing? I'm not trying to cure them of their prostate cancer. These are men who are miserable without it. Some of them have been on testosterone in the past and knew what it was like and were taken off of testosterone when they were diagnosed with prostate cancer. Some of them had been on ADT and couldn't stand it. And some of them just didn't want to be, like they just objected to the idea of having their testosterone lowered, and they wanted improved quality of life. So this is just 7 men. We probably have about double that now. We had a couple of deaths, but I'm going to show you one of them. One of the guys died not from his prostate cancer, but actually because of he'd had radiation, and he died of myelofibrosis. A couple of them stopped. They had biochemical recurrences. Their PSAs were rising. And when their PSA hit 20, they, together with their friendly oncologist, Glenn Bubley, who I work with, said that's enough. And so they stopped it, but really interesting, both these guys thanked us for the couple of years that they both were on testosterone, for the quality of life that they had while they were on it, they and their wives. I want to show you a case. This is the guy I first did with metastatic cancer. He's actually given me permission. He's dead now, and I'm going to show you a story. But before he died, he gave me permission to use his name and his picture. He was very excited. 94-year-old scientist, comes from the Illinois area. He's got like 100 patents, super smart, calls me up and says, and his daughter is a nurse practitioner. She's probably in her 60s. And they're both on the phone, and they call me up and said, "Doctor, I've read all your work. I want you to put me on testosterone." I said, "Well, I can't promise that, but I'd be happy to see you in the office." And his story was that he had metastatic cancer, and he was scheduled to see me, and it got canceled, and he came to see me 3 weeks later. Why was his original visit canceled? Because he developed bilateral ureteral obstruction, and he had percutaneous nephrostomy tubes placed on each side. So he comes to see me about 3 weeks after that's done, and he's great. He's 94, he walks with a cane, he's got a nice tweedy jacket, he's got one bag from the nephrostomy tube in this jacket pocket, he's got the other bag of urine in this pocket, and he walks with a cane, but he gets up on the exam table just fine. He gets off the table unassisted. We sit and we talk some more. And his story was that his PSA was 500 and change at the time. And he'd already been treated with androgen deprivation, and he was so weak with it, he didn't leave the house. Like, he just couldn't get out, and too weak to walk. And I said, "What do you want with testosterone therapy?" He says, "I used to exercise every day. It made me feel good. And I used to communicate with my colleagues," he's a scientist, "around the world by email, and I'm just too tired. And I know I've got prostate cancer all through my bones. I'm going to die of prostate cancer probably. But if I can live better right now, I'd really like it. I feel like my mind isn't as sharp." So I said, you could die. You could die tomorrow. You could die in a week. He says, "Doctor, I've never lived my life in fear, and I don't intend to now. I'll sign whatever you want." I told him I'd never treated anybody like him, but he reminded me of an 84-year-old who was my first guy on active surveillance. And I told him the whole story with that guy. He says, "How old was he?" I said, 84. He says, "I'm 94. I said, "Okay," so I treated him. His daughter, the nurse practitioner, gave him injections of testosterone every 2 weeks. And at 7 months, they sent me this picture of him waiting in the dentist's office. And again, he's given me permission to show this. And he looks pretty darn good for a guy who's now 95 years old. Soon after going on testosterone, he told me his brain was clearer. He started working on his next patent. He started exercising daily. His appetite improved. At no point did he have bone pain. He died at 10 months when one of his nephrostomy tubes fell out. He became septic. His daughter refused to put him in the hospital. He got an injection of IM antibiotics and then went on orals, and he died about 2 weeks later. His PSA at the end was over 2,000. But he had a pretty darn good 10 months run until that point. So he gave me the courage to do this. And at 94, what's the harm, right? Like, we all have to go sometime. But he gave me the courage to start doing some of this in other individuals a little bit younger. This was a gentleman, SP, 61 years old, married. They objected to the idea. They liked alternative treatments. The whole family, the daughter, the wife, they're super smart. They read all this literature. And he also came in to see me with a nephrostomy tube from ureteral obstruction. He had Gleason 9 cancer. He'd undergone a radical in 2011, 4 years earlier. And he had extensive bone mets all through his pelvis. And he was pretty thin. His PSA was 27. He had low free testosterone. And he was weak and he was tired. And he absolutely refused androgen deprivation. He had a good oncologist. He just didn't want it. And he wanted testosterone therapy. And they were aware of this work. I think Sam Denmead at Hopkins is the lead on this. Schweitzer's the first author of this idea of bipolar androgen therapy, BAT. And what they do is the individuals are given Lupron, so they're not making any of their own testosterone. They get a single injection of high-dose testosterone that makes their testosterone go supraphysiologic. And then it drops eventually, and they're down at castrate levels. And then 4 weeks later, they get a T injection again. So they're up and they're down, which is bipolar. That's where the bipolar concept comes from. And they had some remarkable results in a small number of men, 16 with castrate-resistant cancer. And there's a couple of pictures from their publication about nodal disease that shrinks in these guys. Really interesting. And PSAs went down. And so they knew about this. And there's also data, and I think this is Mo Kira's work, yeah, but it's been shown by others, that what a lot of people don't understand about testosterone and prostate cancer is that normal to high levels actually are suppressive for cancer growth. High levels. At low levels, you can increase and you'll get what we call a dose response, and that's what most of us learned. But if you go beyond that, you actually get suppression. So there's an argument for using high-dose testosterone. And so this is his curves. Black is PSA, and the scale is here. And first I just put him on testosterone. He started with a PSA of about 25, got to about 100. It sort of bounced for a little while. And then he got nervous when it went above 150, and he stopped, and he actually went on androgen deprivation for a while, hated it, and then came back to see me after a period of time here. And we decided to do a modification of that bipolar therapy where he was on testosterone longer and off sort of castrate levels for a shorter period of time. And so what I've been doing with him and with others is that they're on high-dose testosterone for a period of 8 weeks, and then for 4 weeks we give him some blocker. In this case it was enzalutamide. And you can see here that his PSA starts down here. Now he's been androgen deprived. He starts at 0. With testosterone treatment at the peak, he rises up here to about 175. He goes on the enzalutamide for 4 weeks, and he's back down close to 0. I don't think he ever hit 0 again, but he's close on this scale. And now this is 2017. He's still on this. We're at 2 years now. And how does this affected him? So he's in Maine. He's an outdoors type. He has sex occasionally with his wife. I spoke to him about a month ago. He had just gone on a hike in the woods for a couple of miles, couple of hours, and was ice skating. He's got a full life. At the end of the 4 weeks of enzalutamide, he's tired, but it's not terrible, and he knows that he's going to get testosterone and feel good again soon afterwards. So here he is. He's, 8 years out from metastatic prostate cancer, living a pretty full life. And I just want to end here just very quickly and just put this out here. So we all know that androgen deprivation helps these men, right? And survival is better. But we're all human beings, and the people we're treating are human beings. I'll just tell you, my father died at 90, and the last 2 years were not good years. I would call him up and I would say, "Dad, how you doing?" And he would say, "I'm just pushing time." You know, his wife would put him, my stepmom would put him in front of the TV, he'd watch something for a couple of hours. He didn't need longer duration of survival. He was an active, accomplished guy. And so, you know, we're all on this, whatever your faith is, or if you don't have any, is like, what are we here for? What's life, right? And I think that for most of us, if not all, we have things that engage us. We're engaged in the world. It gives us purpose. There are things that we want to do. We have hobbies. We have interests. We're interested in our children, whatever it is. And it gives meaning to our lives. Yesterday or the day before, Pat McLaughlin was talking about how these men feel like, some of them on ADT, that they don't even exist. And I see that. And also I see men who are suicidal. If they're not frankly suicidal, they're on the verge of it. I had one patient, not a cancer, well, he was a guy with localized cancer, probably almost certainly successfully treated with a radical. And he'd been on testosterone before, uber wealthy, has houses here, there, and the other. And he came to see me after his radical because he'd been in his happy place, which was his vacation home in the Bahamas. And he was watching a television show, a documentary on medically assisted suicide. And he said he got scared because he realized he was taking notes on how they did it. So he gave himself a shot of testosterone, which he'd been on before. He started feeling better, and he came to see me to find out if he was doing something crazy. This is real. Now, there's some guys, like we talked about, who go on ADT and they barely turn a hair. Sexuality isn't that important for them, whatever. But there's other people in whom an extra 6 months of survival may not make a difference. And what I hear pretty much every patient I've seen with advanced disease says to me, "Doctor, I'd rather live a shorter time feeling well than to live longer the way I'm feeling now." So I'm not telling any of you to change your practices. I put this out really just for you to think about it. We're more than just people following algorithms and stuff. We're actually treating individual patients. And some of them have issues and a whole world around them that doesn't fit neatly into, we're going to give everything to you so you can live longer, because there's a cost to that sometimes. And I just want to, this is my last slide. I would just say, where is it written that every man who dies of prostate cancer must die without testosterone, sexless, weak, and depressed? Thank you very much.